Okay, I would like to introduce the next speaker who presents a talk about a research about the initial results of percutaneous gastric vein antigraft obliterations in patients increased portal vein pressure due to cirrhosis. Dr. Ngọc Hiếu from Bạch Mai Hospital. Please welcome.
Okay, good afternoon, Professor and doctors. My name is Ngọc Hiếu from the Radiology Center of Bạch Mai Hospital. On behalf of my team today, I'm here to present about the initial evaluation of the transvenous embolization for the gastric varices in the portal venous hypertension patient. My presentation has 4 parts. Now we go into the first part to understand about the portal hypertension and the collateral venous circulation. As we know that this is the normal blood flow in the portal systemic, and when there is the liver cirrhosis, the blood flow come back to the liver through the portal vein gradually become more difficult, and it can increase the pressure and the dilate in the portal vein, and then the blood flow can gradually revert, and it can create the it can create the collateral around the portal systemic. And there are some the portal systemic collateral, but the gastroesophageal collateral is the main cause of the gastric varices. And we can see that the gastric varices is located in the deeper with the larger diameter, with the larger size, and moreover is the contact to the gastric environment, and is affected by the stomach movement. So those are the reason why the gastric varices has a high risk of the rupture and is the difficult to endoscopy intervention. And as we know that gastrointestinal bleeding due to the gastric varices rupture is had a high death rate if we untreat. And there are some choice to imagine the gastric varices. Non-selective beta blocker in combination with the endoscopy therapy is the first choice in most emergent case in our hospital. We can quickly assess to the bleeding side, and we can do it again after failed intervention or in rebleeding case. But we cannot control the movement of material, and with some gastric varices are diffuse or difficult to assess, so the endoscopy is not effective. So that was the reason why the radiologic intervention should be considered. To understand the gastric varices structure is include the 3 components. The first one is the portal venous inflow. It includes the left gastric vein, the posterior gastric vein, and the short gastric vein. And the second one is the center of the gastric venous. And the last one is the systemic, the venous outflow. It may be the gastrorenal son, or it may be the esophageal vein, and it's the accessory son. And understand the structure of the gastric varices, we can suggest about the treatment by the radiologic intervention. We have some technique that TIF is the evasive technique that we can create the intrahepatic connection between the hepatic vein and the portal vein. But with the TIF, the frequent complication of TIF is the encephalopathy and the sun stenosis or occlusion. The second choice, we can use the retrograde transvenous. We can assess it from the venous outflow, and we often use the gastrorenal son, and we can do the BRTO or PARTO or CARTO. Nowadays, the PARTO, where the place only in Vietnam that PARTO the regularly practiced in Vietnam is the Bạch Mai Hospital. More than 200 patients have had it done here safely and successfully since 2017. But there are some cases that the gastric varices that absent the gastrorenal son, or the size of the diameter of gastrorenal son is exceeded the maximum size of the plug, so PRATO cannot perform. So there's the reason why the ATO is a recommender. And in the world that there are some, the number of studies have proven the role of the ATO. So we decide to analyze this study with the purpose to evaluate the initial of the ATO technique in the cirrhosis patient with gastric varices. With the indication, we choose the patient with acute or recurrent gastric intestinal bleeding or at risk the rupture that cannot control by the medical or endoscopy. And on MSCD, no have the gastrorenal sun or the size of the diameter gastrorenal sun more than 20 millimeter. And the patient with the recurrent gastrointestinal bleeding after perform the PIRTO technique. And we also have exclusion criteria, contract incident artery and renal failure, portal vein occlusion or no route to assess on the ultrasound, and recurrent massive assisted. And based on the indication and exclusion, we have the participant like those table. And our study design is the intervention study with the longitudinal flow-up with our control group. And during time from the May 2020 to the December of 2023 at the Bạch Radiology Center. And operation fit the inclusion criteria from the duration of the study. We have some variable general feature, gastric varices endoscopy feature, and on the MSCT or DSA feature, and ATO safety and effectiveness. And with the equipment, we have an interventional technique that we use a sheet introducer into the portal vein under the ultrasound, and then we do the portography to check the fitting of the portal vein, and then we we use a catheter to approach and check the draining vein and selective the draining vein flow the assessment, and then we eject the histoacrylic with the lipodone and confirm by the performing portographic again. And then we repeat to the process for each brain and close the entrance by the histoacrylic. During the starting time, we have do the ATO for 50 patients with the general characteristic. Most of the patients are male, and the cirrhosis rates are the hepatic, and more than half of the patients have a childhood B. For the ATO characteristic, we have the 16 patients combined with the PIRTO and ATO. Within the 6 patients fail after PIRTO and 10 patients due to the size of the gastric renal more than the 20 millimeter. And histoacrylic we use for all patients as a occlusion of occlusion material. And the time intervention is around 70 minutes. For example, with this case, a 67 male come to us with the gastrointestinal bleeding due to the rupture of the gastric varices type 3, and we can see that the inflow include the left gastric vein and the short gastric vein, and the gastrorenal sun diameter is more than 20 millimeter. So we don't have the matching block to use this case. So we decide to perform ATO. We assess to the left portal vein assess, and then we do the portography, and we can see this is the gastrorenal sun. And then we do the retrograde approach to the gastrorenal sun and drop the block 2. And we block the invenous, the inflow. And this is the result after intervention. And we have the one patient bleed at the puncture site, and one patient had material migration to the pulmonary artery. And one patient have no bleeding immediately after intervention and after 3 days of intervention. And we have one patient that cannot approach to the afferent feeder, so he has a recurrent bleeding after 7 days. And if we compare with our research, we can see that with the some study in the world, so we have we can prove the role of the ATO. And as I mentioned before, that with the PAITO and endoscopy, they're effective but not at all. So, so with ATO technique can overcome the PAITO limitation, and we can do the ATO in the very able of other case, and the diverse and the material in the ATO are diverse and cheap. So we can have a conclusion that the ATO is the new safe and effective technique to overcome the limitation of the endoscopy and PAITO. And ATO can be applied flexible and widely in many cases with many approaches. Thank you for your listening and your attention.